Morning, this is Dr. Vineet Kinney from the Department of Periodontology, MGM Dental College and Hospital. Today, we'll be speaking about the concept of probing depth, clinical attachment level, and relative clinical attachment level. So, in the context of what happens performing a periodontal diagnosis, we go through the examination where a periodontal probe is usually used. Now, periodontal probe being an ad hoc instrument, which is meant to explore the configuration and the course of a gingival sulcus. So going by that analogy, the commonly used generation 1 probes, as we refer it to as, it would be within what happens with the UNC 15 probe and what happens the Williams periodontal probe, generally which is used in clinical examination. So during the what happens examination procedure, we go through certain kind of reference points during examinations. One would be the free gingival margin, the other being the cement-enamel junction, the third being the base of the sulcus. Now, those of us, what happens, who want to examine for probing depths, we would go for the landmark from the free gingival margin to the base of the sulcus, being the probing depth which we take into context. Now, as we know that in the clinical situation, we get a situation there might be gingival enlargements. So during the course of which the free gingival margin will be coronal to that of the C junction. So in the particular context of disease severity, we always establish that clinical attachment level is always going to be more diagnostic as compared to probing depths. If we see these two comparative scenarios, there is a apical shift of the free gingival margin in context with this area where there is a gingival enlargement which is coronal to the C junction. So although the severity of the disease in terms of clinical attachment loss remains similar, the probing depth on this side is comparatively less compared to that. So for clinical examination perspective, the severity of the disease, the attachment levels are always more diagnostic as compared to that of probing depths. Probing depths have got more relevance in the context of determining the kind of therapy that is going to be required for pocket reduction. Now, in terms of clinical attachment levels, the landmark which has always been used for is going to be the cement-enamel junction and then later the base of the sulcus. So clinical attachment level is taken from the cement-enamel junction to the base of the sulcus, as the case might be. Now, whenever we go for that, the difficulties which we pose with that is that many a times the cement-enamel junction might not be discernible on clinical examination because the free gingival margin might be coronal to it. Second problems are that sometimes the cement-enamel junction is lost as a reference point because of secondary disease process such as caries, abrasions, and abfractions. So in this kind of an event, for wherein an abrasion has obliterated the reference point of the cement-enamel junction, how do we assess attachment levels? So many textbooks, they say restorative margins or the upper or the lower margins of the restoration can be taken about as a reference point, as a surrogate for that of the CE junction. However, the point is these particular things are also dynamic. They change from time to time. So comparing attachment levels over a period of time becomes difficult. So in that situation, we rely upon something called as a fixed reference point. Now that fixed reference point, some probes are manufactured to have an inbuilt circuit to identify certain fixed reference points as in automated probes, but that alternative is very expensive. So in situations like that, for research purposes or for clinical situation purposes, we can manufacture something called as an occlusal stent, where the apical margin of that can be taken about as a fixed reference point. So from the fixed reference point to the base of the sulcus, this measurement can be taken about as a relative attachment level as compared to that of the clinical attachment level, which is going to be there from the C junction. So these comparators would be a surrogate substitute in the case where the C junction is absent. Certain probes, such as the Florida probe with a disc design, are incorporated to use the occlusal plane of the teeth to provide that reference. Some other probes, such as the Jeffcoat probe, is used to see the electrical resistance between the dentine and the enamel to determine that particular electrical reference point from which the particular base of the sulcus can be discernible. Nonetheless, relative clinical attachment levels are referred to as when your particular kind of comparisons will be a shorter period of time, let's say around 6 weeks to 3 months for research purposes, but invariably, more often than not, for clinical examination purposes, the clinical attachment level is better discerned basically from the prospect of identifying the C junction where it is. But that being said, sometimes in certain situations, the teeth supra-erupt. So in that situation, that can also cause a little bit of error in our clinical estimation. So for making a first-time diagnosis or a screening diagnosis, C junctions might be what happens the more reproducible landmark in establishing a diagnosis, a working diagnosis, and a prognosis estimation. But for research perspective and time-to-time follow-up, it might be better to invest in automated probe, which can give you more what happens reproductive values as compared to that of observed value which you get in the clinical attachment level. So relative attachment levels for research and follow-up purposes would be a better reference as compared to that of clinical attachment levels. Thank you so much.